Hello, Ambassadors. This is Kathy with Illinois Maternal. I chose today to record this presentation in hopes that this will help you, since we won't have the time to go through this entire presentation at once. This is the provider version of the presentation. Again, I'm working through this with you because it is the most detailed, and if you can get through this one, then working your way into the consumer presentation will be quite easy. This will also give you a lot of the background that you need to be better prepared to present and answer questions for consumers, as you will better understand the law than if we just worked from the provider presentation alone. That said, I'm not reading from a script, so I'm going to apologize in advance if I get a little tongue-tied or have to say, I wanted this to seem as natural as possible. So we'll go ahead and jump right in. I will do this as if you all are in the room, so bear with me if that's a little weird. Good evening, everyone. My name is Kathy Wallagora, and I am the Healthcare Reform Outreach Coordinator with the Illinois Maternal and Child Health Coalition, and I am here today to talk to you about the Affordable Care Act here in Illinois. We're in the final few months of implementing this important law, and really this is just the beginning. While we're just getting the systems up and running. Good evening, Ambassadors. This is Kathy. I thought I would record this presentation for you all so you can work through this, as you really won't have the opportunity to hear this whole presentation at one time in one of our training sessions as I had hoped. That said, I want you guys to think about how this... Good evening, Ambassadors. This is Kathy. I thought I'd sit down and record my presentation so you all can listen to it in one piece, as I don't think we'll have the opportunity to go through it all at once in the training sessions as I had hoped. I am going to do this presentation as if you're here in the room, but I want you to remember that this is the provider presentation, which is more detailed than the presentation many of you will be giving. My intention in teaching you how to do this one is that I believe if you can do this, you will be prepared to do the consumer presentation and answer questions whenever possible. This is the more detailed version. We will get a little more into the bulk of the law, and it does take about 90 minutes, possibly up to 2 hours to do this presentation, depending on questions from the audience. The electronic version of this presentation is available on our group website. So I'll go ahead and get started. Like I said, I'll be doing this as if you're all here in the room. I hope that you find this helpful. Good evening. My name is Kathy Wallagora, and I'm the Health Reform Outreach Coordinator with the Illinois Maternal and Child Health Coalition. And I'm here today to talk to you about the Affordable Care Act. Here's a little bit about my organization. As you can see, we do a lot of different work. The Illinois Maternal and Child Health Coalition is a policy-focused organization working to improve the health of women, children, and families across the state of Illinois. I could spend a lot of time talking through just the things on this slide, so what I really want to say is if any of this sounds like it's interesting to you or might fit in the work that you're doing, please feel free to email me using the address provided here. As for our presentation today, I offer this picture of Speaker Boehner with the law as evidence of the fact that we simply cannot talk about it all in the time that we have available. This is just the 2,000 pages of law, not the tens of thousands of pages of rules that have really shaped the way this law is playing out in our country. That said, we will dig into some of the more important provisions of the law, talking about those most transformative changes in place today or coming in 2014. So, we'll start off with those provisions improving health today. Many people know that the law was signed on March 23rd of 2010, and many of us know that big changes are coming in 2014. But not very many people realize that a number of changes have already been implemented as of 2010, or over those last 3 years. So we'll start off by just scraping the tip of the iceberg on these early accomplishments. Then we'll talk about 2014, where we really have the most transformative changes taking place, most notably the pathways to coverage for uninsured people available in 2014. The last section of this presentation is really more practical. Once we know about this law, I want to start thinking through how we can get this information into the right hands, and I will share some resources to help you all with that. You will see my contact information again, and I'm happy to take questions at the end of this presentation. Please feel free to be in touch if you need anything. I really hope that we can work through the next few months, which will be very, very exciting for health reform together. So when I think about this law, I try to think of ways to make it easier, right? This is really scary for a lot of people. And one of the ways I've found to do that is to break the provisions down into one of two categories. Now, not every provision of this law falls into one of these two categories, but many of them do. The first is affordability and accessibility. We know at the time that this law was passed in 2010, we had more than 40 million uninsured people in our country. Those folks were uninsured because if you don't have access to insurance through your employer, it's very, very expensive, and odds are you're not going to be able to get insurance on your own. That said, there's also a set of provisions that have to do with the way the health insurance industry works. The health insurance industry is a very large industry that in some ways will impact every person in the country, right? You just can't go your whole life without accessing health care. So this law seeks to place reasonable regulation on those insurance company practices that were most abusive for consumers, those things that resulted in the most people losing access to health insurance, either because of the cost or because of their health status. So this first provision under affordability and accessibility is probably the one that most people in this room look at and say, oh, I knew this law did that. And that's not because I'm judging your intelligence or your understanding of the law, but because I've seen the national polling data. And statistically speaking, this is the only provision that the majority of people in our country can correctly attribute to this law with any sort of confidence. People might tell you they know what the law does, but when we ask them how sure they are, we find they're often guessing. So why do people know about this one, right? It's impacted a lot of people. Over 6 million young people have gained insurance under this provision. But that's not the most impactful provision in place yet. The reason people know about this is because moms are worriers. Moms are worriers by nature, and when moms heard about this, they were very happy, right? People under 26, typically between 20 and 26, are very likely to be uninsured. And the reason they're likely to be uninsured is because it's a very uncertain time in life, and this happens to be a very uncertain time in our national economy. The result is a lot of uninsured young people and a lot of nervous moms. So when people heard about this provision, they ran with it. But what many people don't know is that young people can stay on their parents' insurance until they're 26, regardless of student status, marital status, tax status, or place of residence. This means there is just about nothing that can result in a child under 26 years old being dropped from their parents' coverage. What I like to say is your child can drop out of college, move to California, marry a hippie on the beach, and file taxes on their own, but at least you can rest at night knowing they're insured. And the reason I say that is because I think it illustrates what this law is really about, which is peace of mind, right? Many people, when this law was being passed, said, hey, I'm insured, right? 40 million uninsured is a lot, but it's nowhere near the majority of people in our country. So those people who were insured said, this isn't going to do anything for me. I don't see what needs to change. And while that's not true, we'll talk about some of those changes for people who are insured. It's also important to remember we're all one serious incident away from becoming uninsured, whether that's an accident or a serious illness or losing our jobs, right? This law seeks to provide peace of mind so we know that if those things happen, we still have meaningful access to affordable, high-quality coverage. Now, the provision that's impacted the most people to date is the second bullet point here. And this is a provision requiring preventive and wellness services be provided to most folks enrolled in private health insurance plans without cost sharing. So that means no copayment or no deductible. So the list of preventive and wellness services is pretty long, and it's very specific. It's also pretty intuitive. It includes the things you'd expect, like immunizations, cancer screenings. It also includes some things we're not used to expecting, like smoking cessation programs. So if you're trying to quit smoking, you can actually use prescription drugs or talk to a counselor without having to pay that copayment or deductible. This provision went into effect in 2010, and it has primarily impacted those people who are already insured, right? There are some people who became newly insured, for example, those young people we were talking about. But this is one of those things that has helped those people who already had insurance by guaranteeing access to those services that keep us healthy. The ones I listed, like immunizations and cancer screenings, took effect in 2010. But in 2012, there was another list of women-specific provisions that went into effect. This is a smaller list of preventive services identified as being critical to the health of women, so critical that they should be covered without cost sharing. You can see both the general preventive list and the women's specific list at healthcare.gov. This is an excellent resource for all things health reform. So what was included on that women's specific list? It actually wasn't only services accessed by women, but it did include things like the full range of FDA-approved birth control. That one a lot of people know because it made the news. It also included coverage for things like breastfeeding support and supplies. That means renting a breast pump and seeing a lactation counselor. It included coverage for STI testing, including HIV, right? That one is not women specific, but very, very important for the health of our entire country. The last provision, certainly not the last on the list, but the last that I'll talk about, is coverage for screening for interpersonal and domestic violence. This is really important. This does not mean that when a woman goes to the emergency room presenting with signs of having been a victim of domestic violence, she'll be asked questions. Rather, this means women will be asked questions at their annual preventive visits, right? So when they go see their gynecologist each year or their primary care provider, they will be screened to assess their risk of becoming the victim of domestic or interpersonal violence or the likelihood that they have experienced it in the past. This will allow us to have this important conversation with many women before they reach a point of crisis. It will also allow us to intervene earlier and hopefully prevent this horrific incident from occurring. Now, it's important to know with preventive and wellness services, not all private plans are providing coverage for these, but most are. This is because when the law was passed, folks were afraid of their insurance changing, and so the administration agreed to grandfather all plans existing on or before March 23, 2010, the date that the law was signed. Those plans that are grandfathered do not have to adhere to all provisions, but they must adhere to some. For example, in 2014, grandfathered plans will be barred from denying coverage to adults based on a pre-existing condition. Already, grandfathered plans are not permitted to deny coverage to dependents under the age of 26. However, grandfathered plans are not required to cover prevention and wellness without cost sharing. The way a plan loses grandfathered status is to look new to the market. This means that they will have a change to their benefits or their cost, right? So if an insurance company increases premiums, then they could lose their grandfathered status. As a result, over the last 3 years, we've seen a lot of plans lose grandfathered status. Many of those plans gave up that status voluntarily. Currently, it is believed that only about 23% of employer-sponsored plans are grandfathered. So it's important to know that most people have access to these services, but not all. The best way to find out if your plan will cover this is to call the number on the back of your insurance card and ask if your plan is grandfathered under the Affordable Care Act. Another provision that makes insurance more affordable and accessible are tax credits to help small businesses offer coverage. Many people in our country work for businesses with less than 25 employees, and under this provision, those businesses with less than 25 employees can qualify for tax credits to help cover the cost of insurance for their employees. This is being phased in. In 2014, it will be fully in place, and the tax credit to nonprofit companies will amount to 35% of healthcare expenditures. For all other companies, the tax credit will cover 50% of all expenditures. This is a huge support to businesses that might not otherwise be able to provide coverage. When we think about Medicare, this is a pretty good insurance company, right? So we don't see a lot of changes to the actual benefits package for Medicare. But one change is really important, and that's closing the Medicare Part D donut hole. You may have heard of this coverage gap in prescription drug coverage for seniors enrolled in Medicare. What happens is a senior enrolled in Medicare will purchase Part D coverage to cover prescription drugs, and when they reach a certain annual limit, Medicare stops paying for those prescription drugs, and the senior is expected to pay for those completely out of pocket. Eventually, that senior will reach a new limit, at which point Medicare recognizes that they are spending a lot of money on prescription drugs and will kick back in to continue offering support. Unfortunately, that donut hole is a real barrier for a lot of seniors, especially those seniors with low incomes. Prescription drugs are expensive for all of us, and older adults tend to have many prescriptions that they need to fill. This cost becomes very cumbersome, and oftentimes seniors have to choose to go without coverage or without those prescription drugs because they simply cannot afford them. This donut hole, so to speak, is being closed very slowly. Those two limits are moving closer and closer together until it's completely gone in 2020. In the meantime, it's important to know that the Affordable Care Act goes very far to protect Medicare. In fact, it puts in place a provision that says Medicare benefits can never be less than they are today. So that means that seniors should not expect to see a significant reduction in benefits at any point. Things should only improve. Under the Affordable Care Act, seniors also have access to preventive and wellness services without cost sharing. This is important as seniors, like everyone else, need access to those services to keep them healthy. In Cook County, we have access to a really exciting program made available by the Affordable Care Act called County Care. County Care is the early expansion of Medicaid in Cook County. It is a new Medicaid program providing coverage to upwards of 250,000 people in Cook County who are currently uninsured. So in 2014, Medicaid will be expanded nationwide, and that will happen by eliminating what's called categorical eligibility, thus turning Medicaid into what many people already thought it was, health insurance for people under a certain income. Those of us who are in the know understand that Medicaid is a little bit more complicated than that. Before the Affordable Care Act, in order to qualify for Medicaid, you had to have income under a certain level, you had to be a U.S. citizen or legal permanent resident of 5 years or more, and you have to be one of 5 types of person. You have to be a child, a pregnant woman, a custodial parent, elderly, or disabled. If you are not one of those 5 types of people, it does not matter what your income is, you cannot qualify for coverage under the Medicaid program. This creates a huge gap. This gap actually leaves over 600,000 people with low incomes in Illinois uninsured. So in 2014, we expand Medicaid by eliminating that categorical eligibility, thus only leaving income and immigration status as determining factors. However, a demonstration waiver or pilot program is currently in place in Cook County that allows us to do this now. That is County Care. To qualify for County Care, you must live in Cook County, be between 19 and 64 years old, have income at or below 133% of the federal poverty level. That's just under $15,000 annually for an individual. You cannot currently be eligible for an existing Medicaid program. If you are eligible for an existing Medicaid program, for example, if you're a pregnant woman or a custodial parent, we will enroll you into that program, but we will not enroll you in County Care. Same for Medicare, right? You can't be eligible for Medicare and enroll in County Care. However, if you are eligible for Medicare, we will help you enroll in that program. You must be a legal immigrant for 5 years or more, or a U.S. citizen in order to qualify for County Care, and you must have a Social Security number or have applied for one. Folks who qualify for County Care can access services at Cook County Health and Hospital System facilities and some participating federally qualified health centers. This is also where folks should go to apply. You must apply in person or by calling the phone number on this screen. That's to help manage the demand on our application agents. Folks who have access to County Care have comprehensive health insurance coverage. They have a medical card just like anyone on any other Medicaid program, and the benefits are pretty much the same. There is no cost to enroll in County Care. Now, when we look at industry reform, many of these provisions are related, but they're extremely important for protecting some of the most vulnerable in terms of health status. The first is one that we heard a lot about, right? No denials based on pre-existing conditions for children. In the years leading up to the passage of this law, we heard a lot about pre-existing conditions. Mostly we heard about adults with really scary illnesses like cancer, AIDS, or rare bleeding disorders, right? This was important because those are stories that really helped to build support for this law. But what became lost in all of that is the realization that a pre-existing condition does not mean something that is scary, expensive, and might kill me. A pre-existing condition is any health condition that I had before enrolling in a particular plan. This means that folks could be denied coverage for just about any reason. Common reasons for denying adults, or for denying children, included asthma and allergies. For adults, we know a lot of people were denied based on pregnancy or C-section. So my guess is everybody listening to this webinar right now was born at some point in their life. And because you were born, there's somebody who can be denied coverage based on a pre-existing condition. It's extremely unfair. So this law makes it illegal as of 2010 for children to be denied coverage. In 2014, the same will be true for adults. It's also important to know those children with pre-existing conditions not only have guaranteed access to coverage, but they cannot be charged higher premiums for the same plans. This means that they have meaningful access to health insurance. Related is this thing around lifetime limits and annual limits. So before this law, most private health insurance plans had a lifetime limit of $5 million and an annual limit of $1 to $2 million. This means in a given period of time, that is how much your health insurance provider would pay out for your medical bills in sum. So if you reached a point where your insurance provider paid out $2 million in a year, they would stop paying your bills until your plan year renewed. If you reach a lifetime limit, that means they will stop paying your bills for as long as you live. Now, many of us would never reach either of these limits. Even though it feels like healthcare is very expensive, $1 million and $5 million, that's a lot of money. However, those folks who do reach those limits are those people who most need access to health insurance in that moment. We know when it comes to lifetime limits, the folks most likely to be impacted by this, or some of the people being most impacted by this, were infants born prematurely. It's very expensive to be born prematurely, and you might not know this, but infants typically don't carry their own insurance. So it's very difficult for those children, especially those children who now are considered children with pre-existing conditions, to find new coverage when they reach that lifetime limit. Now with annual limits, so lifetime limits are gone. As of 2010, insurance companies cannot place a lifetime limit on coverage. Annual limits are being phased out and will be completely gone by 2014. Right now, the permissible annual limit is $2 million. Again, for many of us, this doesn't change anything. But when we think of issues of poverty and issues of having low income, this becomes very important. Low-wage jobs typically do not come with health care benefits, but when they do, those benefits tend to be very limited. A great example comes from the fast food industry. We know a lot of fast food companies that do provide coverage do not provide very good coverage. There's one chain which has a presence in Illinois, which provides free health insurance to all of their employees, part-time or full-time, but the annual limit for those employees is just $75. Can't even really go to the doctor with that. Now that's at least free. There is another company we know of that charges premiums of about $10 per month, but then only allows an annual limit of $100 per year. So it's important to know that those folks in low-wage jobs are seeing a huge protection with the phasing out of annual limits, and all of us will have that protection in 2014. It's also important to know that your health insurance company cannot drop you from coverage for any reason except fraud or intentional misrepresentation. This is important because we know a lot of people would be dropped from coverage when they became sick. So obviously all three of those are related. The last provision here, the last bullet point, is around the way that we pay for our health insurance. Many of us have had the experience of enrolling in a health insurance plan, signing a one-year contract at one price, and having the price changed significantly at the end of the year, or maybe even partway through our contract. The Affordable Care Act seeks to help those consumers who experience that problem and the rest of us from unreasonable premiums by using something called a medical loss ratio. The medical loss ratio says that insurance carriers or insurance providers cannot keep more than 80. Let me start over. The medical loss ratio says that insurance carriers must use 80% of my premiums to cover my health care costs. The remaining 20% is theirs to use as they need. They are a business who have employees to pay and lights to keep on. But the other 80% must go to my care. If I'm in an individual plan, they must assess this for me. They will actually look at my premium versus my spending. If I'm in a group plan, they will look at the premiums versus the spending for the whole group. In both cases, if the insurance provider has not met the 80-20 ratio, meaning they haven't spent 80% of premiums on healthcare costs, then the plan carrier, whether that's the individual or the employer, right, for a small group, the plan carrier will receive a rebate check for the remaining amount. We saw the first round of checks go out last summer, and the average check for individual consumers was around $300. So this is helping people to keep costs lower and know that the money they spend is actually going to their care. So that's just the tip of the iceberg, just a few of those provisions already in effect as of 2010, or between 2010 and now. But where we really see the most change is in 2014. So we'll go into 2014 and talk about this. Transformative changes. Again, as I had mentioned earlier, adults in 2014 will be protected from denials based on pre-existing conditions. Insurance companies cannot use health status to make any decisions. This means no denials, but this also means they cannot charge higher premiums to adults. So there is an important protection for those of us who have pre-existing conditions, which when you think about how pre-existing conditions are defined, could mean a lot more of us than you may have realized. There's also this practice of gender rating that becomes illegal in 2014. Gender rating is the practice of charging women higher premiums for the exact same coverage, and it is extremely commonplace. In Illinois, 100% of plans are gender rated, and the average woman is paying 25 to 50% more than the average man. Again, we are paying higher premiums for the exact same coverage. Insurance companies have said that this is because of the cost of childbearing. However, economists have looked at this and found that when you control for the cost of maternity and newborn coverage, women are still paying significantly more than men. Insurance companies have also said that they charge men more later in life. However, when we looked into it, we found that what they meant was they were charging men more after 65 years old, when most men are enrolled in Medicare. This means that there is no justification for this higher cost, and that means it's gender discrimination. And that's why in 2014 it is not allowed. This, combined with guaranteed issue, is actually really important because it gets to this bigger issue of premiums. How is it decided what we pay for the care that we receive? In 2014, this will become much more simple because there will only be 3 factors that can determine your premium. Where you live. So there are 8 rating areas in Illinois. These are areas where the cost of accessing health care is simply different. So the cost of health insurance is different. So folks in different rating areas may pay different costs. The second factor is your age. So folks who are older can be charged higher premiums than those who are younger. However, there is a protection in place. The oldest adult enrolled in a plan cannot pay any more than 3 times that of the youngest adult. This may still sound like a lot, but most older adults enrolled in private health insurance are currently paying upwards of 9 times that of younger adults. And finally, you can be charged a higher premium if you self-report that you are a cigarette smoker. If you are a smoker, you can be charged up to 1.5 times that of a non-smoker. This is self-reported, but it's important to know if someone lies about their smoking status, that is considered intentional misrepresentation and can be grounds for losing access to health insurance. So we've talked a lot about how you'll access coverage, right, or how people have new access to coverage or how they'll pay for it. But what we haven't talked a lot about is the quality of that coverage, and that becomes really important. So in 2014, the essential health benefits come into play. The essential health benefits are 10 broad categories of coverage outlined by the federal government that become the standard for health insurance across our country. So in 2014, every plan must meet some minimum requirements for coverage. The federal government outlined broad categories, meaning things like hospitalization or prescription drug coverage, and they're leaving it up to the states to define exactly what that means based on the health care and financial needs of that state's residents. However, there are a few provisions on which the federal government was a bit more specific. One is that provision around prevention and wellness, right? We already talked about this, and the law is very explicit in what is and is not covered under this provision. Maternity and newborn coverage is pretty self-explanatory, but the law specifies that this must mean labor and delivery costs as well as prenatal care. The states have the opportunity to go further in that. The last category is actually really important when we think about the implications, the overall impact of this law. And that is a requirement for all plans to provide coverage for mental and behavioral health services. This is important because many people don't have access to these services in their insurance plans. More importantly, this provision requires what's called parity in coverage between mental health and medical health. So that means if my plan provides coverage for certain medical health opportunities, right? So if I can go to an inpatient facility for 3 days for a medical health condition, that means I can go to a inpatient facility for 3 days for a mental health condition. If I have prescription drug coverage for a medical condition, I have prescription drug coverage for a mental health condition. This is parity, equality in coverage. Currently, or before this law, plans with 50 people or more are required to provide parity. But the vast majority of Americans are actually in smaller plans, and this law extends that coverage to every single plan. Every plan sold in the country must provide parity in medical and mental health coverage. This is important because it creates a really important opportunity to provide more services to more people. It also allows us to shift our thinking It also allows us to shift our thinking in the way that we approach mental and behavioral health, right? We run something of a crisis management system right now, seeing folks who have mental and behavioral health issues only at their lowest point. This law, in providing parity, will allow us to look at mental and behavioral health more like we look at medical health. That means we can see people earlier and maybe even prevent diseases. Think of diabetes. If diabetes was a mental illness, we wouldn't see people until they were going to lose their feet, or maybe even just after. But now, we're going to start treating those mental illnesses more like diabetes, meaning screening and early intervention. Now, the most important thing to talk about when we talk about 2014 is these new pathways to coverage, for affordable coverage for those who are uninsured. These are 3 distinct but overlapping pathways, and they actually overlap more than this Venn diagram would imply. I hope that will become clear as I talk. So we'll start off by talking about tax credits and subsidies. This law is called the Affordable Care Act, but we didn't just call it that because it sounded nice. We called it that because we actually determined what is affordable health insurance. Folks who were involved in writing this law sat down, they did the math, and they determined that no person should be expected to pay more than 9.5% of their annual income on health premiums. So I'll say that again. In 2014, no person will be expected to pay more than 9.5% of their income on their health premiums. This is huge because when we define affordable, when we establish this threshold, that means we must take steps to keep people underneath that threshold. And that's what these tax credits and subsidies are meant to do. Now, most of us have insurance through our employers. And many of us will work for large employers with 50 employees or more. In 2014, those large employers are required to provide coverage, and that coverage must be affordable. So that means many of us will just be asked to pay less or may already be paying under 9.5% when it comes to our share of the premium. For those folks who do not work for mandated employers, those employers with more than 50 employees, or for people who do work for those employers but they are not providing affordable coverage, tax credits and subsidies become available. Tax credits will effectively be discounts on our premiums each month. You can take this tax credit at the end of the year just like any other, right? So you can pay out your premiums all year long and then get a larger tax return at the end of the year. Or you can advance these tax credits, meaning that you will have access to tax credits, or you will estimate your income at the beginning of the year, and based on that estimate, have access to a certain amount of tax credit. Rather than waiting until the end of the year to get that money back, you will pay less in premiums each month, and at the end of the year, that check will go to your health insurance carrier. Tax credits are available to folks between 100% and 400% of the federal poverty level. That's about $93,700 for a family of 4, almost double the average income for a family of 4. In addition, there will be subsidies to help people cover out-of-pocket expenses. This is for a smaller subset, people with incomes between about 100% and 250% of the federal poverty level. But these will help to pay deductibles and copayments and other out-of-pocket expenses. It's important to know we are all protected from high out-of-pocket expenses. So you're not going to get a premium of only $100 a month, but a deductible of $10,000 a year. There will be a protection. You can learn more about both of these at the Kaiser Family Foundation website, kff.org. They actually have a really cool calculator that you can use. Plug in some information about yourself and learn what you may have access to in tax credits and subsidies in 2014. It's important to know tax credits and subsidies are only available to U.S. citizens and lawfully present immigrants. There is no waiting period for lawfully present immigrants. However, it's important to know that deferred action youth are not considered lawfully present for purposes of the Affordable Care Act and accessing tax credits and subsidies. The other way we're going to help people pay for insurance is with an expansion of the Medicaid program. So we talked about this a little bit earlier with county care, but I'll just summarize. In 2014, we will expand Medicaid nationwide by eliminating categorical eligibility, which currently creates a huge gap in coverage. Categorical eligibility means in order to access Medicaid, you must be one of 5 types of person. You have to be a child, a pregnant woman, a custodial parent, elderly, or disabled. If you are not one of these 5 types of people, then you do not have access to Medicaid before the Affordable Care Act. In 2014, we eliminate that requirement and open Medicaid to any U.S. citizen or legal permanent resident of 5 years or more with income under 138% of the federal poverty level. That's just over $15,000 annually for an individual. It's important to say for an individual because most people who fall into this coverage gap are childless adults. There are, in fact, about 618,000 people in Illinois who could be eligible for this expanded Medicaid program. The Medicaid program, or the Medicaid expansion, is 100% federally funded in the first 3 years. After the first 3 years, that federal funding gradually decreases to 90% by 2020, never dropping lower. The Supreme Court decision changed this coverage ever so slightly. The way the law was written, it said every state must expand Medicaid. Those states that do not would not be allowed to participate in the Medicaid program, thus losing a significant amount of federal funding. The Supreme Court determined that that was federal coercion because the amount of Medicaid funding is so significant for most states. It accounts for about 10% of most state budgets. So the Supreme Court said that the federal government could encourage expansion, it could support expansion, and it could fund expansion, but it could not take away existing Medicaid funding. This, in effect, made the Medicaid expansion optional, and many states had to take an extra step. Some states have chosen not to expand. In Illinois, we did pass legislation authorizing this expansion, and in 2014, we are happy to say that folks will be covered under this new program. Now, the marketplace is actually not a type of health insurance, but rather the place where we will be able to purchase our health insurance. The marketplace will open for enrollment on October 1st of 2013, with benefits available beginning January 1st of 2014. This is the only place that folks will be able to access those tax credits and subsidies in advance. So I'll tell you a little bit about who uses the marketplace, then we'll talk about what the experience will be like. Folks using the marketplace in 2014 will primarily be individuals working for businesses with less than 50 employees. Those small businesses will be able to go on and purchase group coverage using the marketplace. Again, meaning those businesses with less than 50 employees. Others using the marketplace will be those who qualify for public health insurance programs like Medicaid. Elected officials are the only people required to use the marketplace. So members of Congress in 2014 must access their coverage here. The process by which this will work for folks, individuals will go to the marketplace and fill out what we call the single streamlined application. We call this application single because it is one bit of paperwork to access tax credits and subsidies, Medicaid, and private health insurance. We also call it single because it allows you to move between public programs and from public to private health insurance programs. So I'll give you 2 examples of this, right? The first example would be somebody who works for a small business that does not offer coverage, right? So I, as an individual, would then go to the marketplace and use tax credits and subsidies to purchase private health insurance. If I lose my job partway through the year, because I've already been to the marketplace, I do not need to go back and fill out a whole new application. Instead, I will be able to report only the changes and be moved into a new program. Additionally, or the other example would be someone enrolled in Medicaid programs. For example, a woman who's uninsured when she finds out she's pregnant. This woman will enroll in 4 different programs over the course of her pregnancy. First will be something we call Medicaid presumptive eligibility. We provide coverage to most pregnant women under Medicaid because pregnancy is such an important time for our health care. This means that most women are presumed to be eligible for Medicaid, but that does require a little bit of paperwork for their doctor to be paid for the services they provide that day. Medicaid presumptive eligibility only covers early prenatal care. A woman will also have to fill out an application for a program called Moms and Babies, which provides coverage for later prenatal care and labor and delivery. However, Moms and Babies only covers mom up to 60 days postpartum, so she will need to enroll in family care to continue to receive coverage as a custodial parent after those 60 days have passed. In addition, she will need coverage for her child. Moms and Babies provides coverage up to 1 year, but many women like to move their child into All Kids sooner. All Kids is our program covering children. Each time a woman moves from one program to the next, she needs to complete a new application before the Affordable Care Act. It's very cumbersome, can take a lot of time, and it often results in women having gaps in coverage. The Marketplace, using a single application, makes it possible to move between those programs by only reporting changes if the application has been filled out once in the year. This is a really important opportunity for those folks who use Medicaid to have better continuity of coverage. We call this the single streamlined application because the application, while it covers all of these different programs, is relatively short, only 3 to 7 pages depending on your family size. This might sound like a lot, but the first draft is actually 25 pages long. This is also an online application and it's dynamic, so my answer to question 1 will determine whether or not I see question 2. We expect it will take the average person applying for a family of 4 about 45 minutes to fill out this application. However, those folks with limited English speaking skills or who may have a lower educational attainment or other obstacles will find that it could take longer. Once folks have completed the application, they will find out what kind of financial support they have available to them. So you will know if you have access to tax credits and subsidies to help pay for coverage before you ever have to look at plans. You will also find out right away if you qualify for the Medicaid program or for other public health insurance programs. We say that there's no wrong door with the Marketplace. No matter who you are or what programs you'd like to access, you can find them or be connected to them on the Marketplace. I say be connected because not quite everything will be there. For example, Medicare has a really great enrollment system that a lot of older adults are very comfortable with. So instead of making older adults learn a new program when the other one was working just fine, we have decided not to include Medicare in the Marketplaces. That means someone over the age of 65 who comes to the Marketplace will not be told, sorry, nothing here for you. They'll be told, it looks like you might qualify for Medicare. Here's where you can find more information and apply for that program. If you do not qualify for Medicaid, you will be able to then look at I shouldn't say that. I should say, if you do not qualify for Medicaid and would like to, you can look at private health insurance plans, right? So folks who qualify for Medicaid are likely to enroll in that program because it'll be the most affordable. But with availability of tax credits and subsidies, people between 100 and 400% in the federal poverty level will find that private health insurance in the Marketplace becomes much more affordable. So those folks will go into the Marketplace shop and begin looking at and comparing private health insurance plans. This is where the Marketplace becomes really cool. Marketplaces are only allowed to offer high-quality, qualified health plans that meet provider network standards and offer at least the essential health benefits package. The Marketplace also gives consumers the tools and power to have control over their insurance decisions. And the way it does this is by allowing us to compare plans on the same points or make an apples-to-apples comparison. The reason this is possible is because of something called the standard definition of benefits. Many of us are familiar with the definition of benefits, right? That's the booklet, the very thick booklet that your health insurance company would give you every year. That booklet usually had paper thin or very, very thin pages with tiny, tiny print, right? And you were expected to comb through there, read every page to really understand your coverage. Because of the Affordable Care Act, those books are gone, and every health insurance plan must use the same short, standardized definition of benefits. Just 6 8.5 by 11 pages. Double-sided, single-spaced, 12-point font. In this standard definition of benefits, insurance companies will not be able to use insurance jargon. Where they can't get away from jargony words, things like premiums or copayment, they will need to define those words. In fact, the words are defined on the very first page in a way that is very easy for consumers to see and understand. In the standard definition of benefits, insurance providers must talk about the same things in the same places. This means I could open up to page 3 of the standard definition of benefits for every plan sold in the state of Illinois and have the same information about each plan. And that's just in the paper version. When we think about the marketplace, which is an electronic tool, right, this is us going online, that means that there are a lot of opportunities to dynamically organize information. And that's exactly what happens. The marketplace will show you the same points for the same plans side by side so you can understand where they're the same and where they're different. And it will allow you to organize plans based on information that matters to you. So this is really hard for a lot of people to think about, right? Because it's so hard for us to think about actually shopping for health insurance. But this is not a new idea. We have been comparison shopping for products on the internet for quite some time. We've even been doing this with some insurance products. Think of websites like eInsurance that will sell you homeowners and auto insurance. This just applies that principle to private health insurance. I think the best website that currently exists to help us think through this is Expedia, right? People are pretty familiar with it, and the process is pretty similar to using the marketplace. Folks using Expedia go online and fill out an application, so to speak. We tell Expedia things that the federal government needs to know when we're purchasing airline tickets, right? You essentially check the box that says, I'm not a terrorist. Then you provide information that the airlines need about you when you're purchasing airline tickets. For example, where you're flying from and where you want to land. But then you can also provide information about preferences. You can say things like, I really don't want to have a layover, right? I'd like to just have a direct flight. Or you can say that you'd prefer to fly in the morning or the evening. The marketplace will allow you to do something similar. You'll be able to look for plans in the marketplace based on network or benefits package. So you'll be able to say things like, this is my primary care provider. Make sure they're in network. Or this is a service I like to access that goes above and beyond the essential health benefits. Maybe you really like to go for acupuncture treatments. You'll be able to ask the marketplace to show you those plans that include acupuncture. Once you fill out the application on Expedia, then you see a chart, right? A very simple chart that says Delta Airlines leaves Chicago at this time, arrives in Orlando at that time. United Airlines leaves at this time, arrives at that time. And for each one, you'll see whether or not there's a layover, where that layover is, how long that layover is. And you'll be able to see other information about the airlines, including quality ratings and cost. You can then go on and organize or go up to the drop-down menu and organize that chart, right? You can see it price low to high, price high to low, earliest departure time, latest departure time. This allows you to think about the things that matter, have multiple points that are important to you, and work through all of that information in the same way. For example, when I purchase airline tickets, the most important thing to me is cost. So I always organize price low to high. The second most important thing is usually having a direct flight. So I can then find the cheapest flight with no layover very quickly. This gives me control, right, and information and tools that make makes purchasing an airline ticket much easier than it was before. That is what the marketplace will do for health insurance. Now, health insurance is not an airline ticket. You will need something more complex than just that little chart. But the feeling, the experience will be very similar. There will also be a tool on the marketplace to help you understand the actual cost of a plan. So in addition to being able to prioritize those things that matter to you and see the information you want, you'll be able to make a more concrete decision in whether you should purchase a high premium plan or a high deductible plan. Marketplaces will only be available to U.S. citizens and lawfully present immigrants for subsidized or unsubsidized coverage, right? So again, there's no waiting period, but you must be lawfully present. And again, for purposes of the Affordable Care Act, deferred action youth do not count as lawfully present immigrants. So the last thing we'll talk about with the Affordable Care Act is this individual mandate. This is the thing we heard a lot about, right? The requirement to purchase coverage, and it's easily the most contentious part of the law. The individual mandate requires most Americans to purchase health insurance beginning on January 1st of 2014 or pay a penalty if they do not comply. There are certain people that are exempt from this penalty. You are exempt from the mandate if you would have to spend more than 9.5% of your household income on a qualifying health plan, even with tax credits and subsidies and other supports put into place. You are exempt if your income falls below the threshold for filing federal income taxes. That's because we'll report our insured status at the same time that we report that we file our federal taxes. If you have an income so low that you do not have to file federal income taxes, you likely qualify for Medicaid. So those populations will be an important outreach group, though they are not required to pay a penalty if they're uninsured. Finally, if you are undocumented or you are not a lawfully permanent resident, you are not required to be insured. This is an important point because we have not offered affordable coverage to those populations. Those people who are already insured, whether through private or public health insurance, maybe you have Medicaid, Medicare, or insurance through the Veterans Health Administration, those folks with any insurance of any kind are already meeting this requirement and do not need to do anything differently. So most of us are already doing this, and many of those people who are not insured probably want to be anyhow. That penalty in the first year is very small. It's only $95 per person, 50% less for children, so around $40 in the first year. It is a phased-in penalty, so it'll be $95 in the first year, about $300 in the second year, about $600 in the third year, eventually climbing up to $2,000 or 2% of a person's income. It will always be cheaper to pay the penalty than it will be to purchase health insurance. It's also important to know that the penalty is not a hard penalty. So while the IRS does have the authority to tack this onto what you owe to your taxes or to take it from your tax return, you cannot have health insurance penalty evasion, right? You can't go to jail. Your wages won't be garnished. There cannot be liens assessed against you. So it's a relatively soft enforcement. That said, it's really important. We are requiring a lot of health insurance companies in this law. And if we didn't require people to purchase insurance, it would drive up the cost of insurance to sky-high levels, right? This is because of the guaranteed issue thing. If we allow anybody to access health insurance, regardless of their health status, but then don't require people to become insured before they become sick, most of us would wait, right? Think of your auto insurance. We are required by the government to purchase auto insurance. We cannot purchase auto insurance once we're in an accident. If we did not have the individual mandate, this is what would happen for health insurance, and that would be really bad for a lot of people. So that's the law. Now I just briefly want to talk about connecting communities, right? Because the biggest problem we have in implementing the Affordable Care Act is getting the information out there. And it's really important that we work with healthcare and social service providers to get this information into the right hands. So a little bit of background. In the Chicago area in 2014, there are about 550,000 uninsured people, or 19% of the population, that will have affordable health insurance coverage available to them through new health insurance, or let me start over. In Chicago in 2014, there are about 550,000 uninsured people, or about 20% of the population, who will have new affordable health insurance available to them. Most of those 500,000 people will qualify for the new Medicaid program or have access to tax credits and subsidies in the marketplace, right? That means most of these folks have incomes under 400% of the federal poverty level. A smaller group, about 70,000 people, are currently uninsured but have incomes over 400% of the federal poverty level. We can guess that most of these folks are young people who have relatively high-paying jobs that choose to go without insurance. This will also include some folks who are have pre-existing conditions and are denied access to coverage. It's important to know all of these numbers are a little bit lower, right, because they're complicated by the number of undocumented people in the Chicago area. But we expect most of those undocumented, right, fall into the first two groups, probably primarily into the new Medicaid group. We know a little bit about these groups. So we know Kaiser Family Foundation has done some research every month since the law was passed. And they've asked people, do you feel that you have enough information about the law to understand how it will impact you or not? 57% of people say they do not have enough information about the law. It's not surprising, but it is important. More importantly, we know that when we look at low-income households and those who are currently uninsured, the number of people who don't understand the law is significantly higher. This is concerning because those are the two groups who stand to gain the most from this law. Now, another organization, Enroll America, they're a national nonprofit devoted to connecting folks to insurance made available by the Affordable Care Act. Enroll America has built on this research by talking to those people who do not understand the law and who qualify for tax credits and subsidies or Medicaid. And we've asked them, or we've explained the law to them, told them about the marketplaces, said, okay, so that sounds great, right? You're going to use this resource. Will you log on yourself and access insurance? The vast majority of people, 78% of people, say they would not log on to the marketplace to access affordable coverage themselves. This is because people have really bad experiences with health insurance, right? We've all been burned. They did some focus groups and they released this word cloud of reasons people gave for not feeling comfortable using this system. And the words it included were things like anger, nervous, frustrated, scared, confused, right? Not good words. That's what we have to overcome. So we've asked folks, if you don't want to do this yourself, who do you want to help you? And there were 3 answers that came up most often. The first was my healthcare provider, my doctor or my nurse, or even the receptionist at my doctor's office. It's not surprising. We are very trusting of our healthcare providers, especially on issues related to healthcare. The second answer was my mom. This isn't surprising, right? A lot of us turn to our moms for a lot of things, but it's not a group we can really do a lot about on a systemic level. The third answer was my social service provider, my case manager, my social worker, the person who owns the homeless shelter or the food pantry that I go to, or even my faith leader, right? My priest or my rabbi. This becomes really important. These 3 groups together, especially those provider groups, are the groups that need to be getting this information out. We know that there's a role in outreach for everyone. It takes someone 7 times hearing something and 7 times hearing something to remember it and 30 times hearing something to actually take action. That's why you see the same movie trailer over and over and over. Well, fortunately, the Affordable Care Act anticipated that folks would want assistance and that there would be a great need for outreach. And so they built this in-person assistance network. There are technically 3 different groups under this umbrella, but what's important to know is these 3 groups will be working together to identify vulnerable populations, conduct outreach to those populations, facilitate enrollment. So this means we're building awareness for the law, and then we're actually walking people through the marketplaces, helping them understand tax credits and subsidies, helping them fill out the application, and providing advice on health insurance plans. These 3 groups here cannot be health insurance providers. They also cannot accept money from health insurance providers to enroll folks. It must be unbiased, free of conflict of interest. These folks are also specifically barred from saying purchase this plan, not that plan, right? We have to be providing advice so we can help people think through the process but cannot tell them which plan to buy. And finally, these groups will be a supportive network to provide ongoing support to those folks who become insured. Just because I'm insured does not necessarily mean that I know how to use my insurance. So it's important that I have somebody to call when I have a question or don't understand something that was sent to me. But there is a role for everybody. For those folks who are not applying or have not applied to become navigators or in-person counselors, you should still understand the law. You should be able to talk about this law and should initiate conversations with clients when appropriate. We've established a few resources to help you with that. Obviously, hosting presentations like this are an important way to get this information into the right hands. We also have a series of webinars that are available to download from our website. Once you understand the law, you should initiate conversations with clients whenever appropriate. We try to create a culture of health coverage by leading with the statement, you have affordable coverage options available. I don't have to know much about you to know that that's probably true. Then we can go into deeper conversations about exactly what that means. We're sharing educational resources with folks. And IMCHC has some of those available. Healthcare.gov is another great place to go for resources. And when possible, connecting clients back to those in-person assister networks like navigators and in-person counselors. Here are some resources for staying up to date on the law. These are the places that I go for information when I need it. Our Illinois Maternal website has our webinars. It has podcasts, our resources available. Illinois Health Matters is an Illinois-specific implementation website. This has great resources to understand the needs in Illinois. It also is great for understanding the law in general. Healthcare.gov is the official Affordable Care Act website run by Health and Human Services. It is a great resource for understanding the law. There are also really good consumer resources there. Health Reform GPS is for those policy nerds who really want to stay on top of implementation. Kaiser Family Foundation is an excellent national resource on the Affordable Care Act. They have great infographics and interactive tools that you can use to better understand or explain this law. The National Women's Law Center is obviously an organization focused on the needs of women. They have great resources about this as well. Health Insurance 101 is a consumer interfacing website to help you understand insurance and help you to understand the Affordable Care Act. And finally, Enroll America. Enroll America is a national organization. You can use this website to find resources and tools to use in outreach, as well as best practices for outreach, enrollment, and messaging. If you have any questions, please feel free to be in touch. I would like to be of support as much as possible, and I know you're not going to remember everything I said today. With that, I'm happy to take some questions right now. So, ambassadors, that was the whole presentation. It's long. I hope you don't feel completely terrified. I am 100% confident that we can all work through this together, and you'll be prepared to do this presentation as well as the much easier consumer presentation. I also apologize if you heard my dog barking in this at all. She's a little jumpy with these storms. Anyway, thank you guys so much. Please let me know if you have any questions. Please feel free to be in touch. Use our Google group to be in touch with the entire group. Thanks so much.